a comprehensive examination of prescription and over-the-counter medications that may accelerate cognitive decline and dementia in seniors. The rising tide of dementia is one of the most pressing public health crises of our time, often mistakenly attributed solely to the unavoidable process of aging. While the statistics are grim, a new diagnosis is made approximately every 66 seconds. New research is shifting the focus from natural senescence to the contents of the average senior's medicine cabinet. This comprehensive analysis will explore the alarming, yet largely unknown link between common, widely prescribed, and over-the-counter medications and the acceleration of cognitive decline, memory loss, and dementia. The central, terrifying revelation is that for decades, the potential cognitive risks of certain drug classes have been known within pharmacological circles, yet this critical information often fails to reach the patient or even the prescribing physician with the urgency it deserves. The impact is profound. Studies suggest that key memory centers in the brain, particularly the hippocampus, may shrink by over 28% in less than a year in vulnerable seniors exposed to certain medications. A significant body of evidence, including a 2023 study highlighted in Neurology and Aging Research, indicates that specific drug categories can increase the risk of dementia by as much as 49% within just 2 years of use. This document will systematically reveal the 9 most concerning medication groups, ranked by their prevalence and potential for harm, culminating in the single greatest chemical threat to the aging mind, anticholinergic polypharmacy, understanding the brain's chemical basis for memory. To comprehend how these medications wreak havoc, one must first understand the core mechanics of memory. The brain's function is governed by chemical messengers called neurotransmitters. For memory, attention, and executive function, 3 are paramount and are targeted by the drugs discussed. Acetylcholine, ACH, the memory molecule. It is essential for forming new memories, learning, and maintaining a state of alert awareness. The hippocampus, the brain's primary memory factory, is heavily reliant on acetylcholine. GABA, gamma-aminobutyric acid, the calming molecule. It is the brain's main inhibitory neurotransmitter, reducing overstimulation, promoting sleep, and easing anxiety. Dopamine, crucial for executive function, motivation, emotional regulation, and decision-making. Any substance that significantly blocks, antagonizes, or overenhances, agonizes these chemicals in an uncontrolled way can destabilize the intricate balance required for healthy cognition. The 9 most dangerous medications and classes. The following 9 categories are ranked based on their documented risk profile and prevalence among the senior population. Medication number 9, diphenhydramine Benadryl, the silent anticholinergic. Diphenhydramine, commonly marketed as Benadryl, is a quintessential over-the-counter OTC drug found in nearly every household. It is trusted for soothing allergies, alleviating cold symptoms, and crucially as a sleep aid, often labeled PM or nighttime. Its accessibility belies its potency as a cognitive disruptor. Mechanism of harm. Anticholinergic blockade diphenhydramine belongs to a class of drugs known as anticholinergics. Its primary action is to block the effects of acetylcholine, ACH. While this blockage dries up nasal passages, good for allergies, and causes drowsiness, good for sleep, it simultaneously disrupts the hippocampus. For the older adult, whose natural ACH levels are already lower, this chemical interference can be devastating. The evidence. A 2023 study in the Journal of Geriatric Cognitive Health revealed that seniors who regularly used anticholinergic drugs had a 54% higher risk of developing dementia compared to non-users. The cumulative effect, even at OTC doses, is a chronic, low-level chemical fog that eventually accelerates the pathology of decline. Safer alternatives. Avoid all products labeled PM or nighttime, as they almost always contain diphenhydramine. For allergy relief, non-sedating alternatives like loratadine, Claritin are preferred, as they are less likely to cross the blood-brain barrier and interfere with central nervous system function. For sleep, behavioral changes, sleep hygiene, and non-anticholinergic supplements should be prioritized. Medication number 8, proton pump inhibitors, PPIs, the nutrient thieves. Medications such as omeprazole, Prilosec, and esomeprazole, Nexium, known as proton pump inhibitors, PPIs, are widely used to treat chronic heartburn, GERD, and acid reflux. They are often taken for years, sometimes decades, which is a significant clinical concern. Mechanism of harm: nutrient malabsorption, and amyloid plaques. PPIs work by aggressively suppressing stomach acid. While this relieves reflux symptoms, stomach acid is vital for the proper absorption of key micronutrients, most notably vitamin B12. B12 is crucial for maintaining the myelin sheath, the protective coating around nerves, and for supporting optimal brain health, memory, and mood stability. Chronic B12 deficiency mimics the early signs of Alzheimer's disease, causing confusion and memory lapses. Furthermore, PPIs have been implicated in increasing levels of amyloid beta plaques, the toxic protein aggregates considered a core driver of Alzheimer's pathology in the brain. The evidence: a large-scale 2016 study published in JAMA Neurology examining over 73,000 older individuals found that regular PPI users had a 44% increased risk of developing dementia compared to those who did not use the drugs. Safer alternatives: if prolonged use is deemed necessary, supplementation with B12 is critical, though absorption may still be impaired. Safer pharmacological alternatives include H2 blockers like famotidine, Pepcid, which are less likely to interfere with B12 absorption. Natural approaches, such as using deglycerinated licorice, DGL, can coat and soothe the stomach lining without interfering with acid production to the same aggressive degree. Medication number 7. Bladder control medications, targeted acetylcholine disruption. Drugs like oxybutynin and ditropan are commonly prescribed for urinary incontinence or overactive bladder in seniors. This is a practical solution to a common and embarrassing problem, but the trade-off is often cognitive. Mechanism of harm: direct central anticholinergic action. Oxybutynin operates by the same principle as Benadryl, blocking acetylcholine ACH. However, this medication is highly effective at crossing the blood-brain barrier, directly impacting memory centers in the hippocampus. For seniors, a practical solution to bladder control often becomes an engine for accelerated mental decline, a consequence rarely warned about. The evidence: a 2019 study published in the BMJ found that individuals over 65 who took potent anticholinergic medications like oxybutynin for more than 1 year had a 49% higher risk of developing dementia. The mental changes, forgetfulness, brain fog, and struggle to follow conversations are often tragically misattributed to normal aging. Safer alternatives: newer medications that work via non-anticholinergic mechanisms, such as mirabegron Myrbetriq, are generally considered significantly safer for older adults as they avoid the critical cholinergic pathway. Medication number 6. Statins, starving the brain of essential fat. Statins, including common drugs like simvastatin, Zocor, and atorvastatin Lipitor, are among the most prescribed drugs globally for lowering cholesterol and reducing cardiovascular risk. Mechanism of harm: cholesterol depletion in the brain. The brain is composed of nearly 60% fat, and cholesterol is a non-negotiable component required for creating and maintaining the myelin sheath, the protective coating that ensures rapid, smooth nerve signal transmission. Aggressively lowering systemic cholesterol with a statin can also starve the brain of this essential building block, leading to neuronal inefficiency and reduced function. The evidence: a 2023 study published in Frontiers in Aging Neuroscience indicated that seniors over 70 who had been on statins for more than 3 years had a 26% higher risk of developing mild cognitive impairment. Some patients report sudden, acute memory loss, inability to recall names, or difficulty navigating familiar routes. Nuance and alternatives: it is crucial to note that not all statins cross the blood-brain barrier equally. Water-soluble statins, such as pravastatin and rosuvastatin, are generally considered less risky in terms of cognitive side effects than lipid-soluble ones like simvastatin and atorvastatin. Any sign of cognitive fog on a statin warrants a discussion with a physician about dose reduction or switching to a safer formulation. Medication number 5. Benzodiazepines, the chemical sedation trap. Benzodiazepines, benzos, including lorazepam, Ativan, diazepam, Valium, and alprazolam, Xanax, are prescribed for anxiety, acute panic, and sleep problems. They are often perceived as a necessary lifesaver for easing mental distress. Mechanism of harm. GABA overenhancement and neurosedation benzodiazepines work by enhancing the effects of GABA, the brain's primary calming chemical. They chemically sedate the brain, quieting anxiety and promoting sleep. However, this prolonged sedation slows neural activity, making the brain less flexible, less efficient at learning, and highly prone to confusion, memory gaps, and a characteristic emotional dullness. The evidence. A 2022 study published in the BMJ tracked over 8,000 seniors and found that those who used benzodiazepines for more than 3 months had a 51% increased risk of developing Alzheimer's disease. The risk is even higher for long-acting benzos like Valium, which accumulate in the body's fatty tissues, including the brain. The withdrawal risk. The most dangerous aspect of chronic benzo use is dependence and severity of withdrawal symptoms, anxiety, agitation, rebound insomnia, which trap the user, making the drug feel essential even when it is the source of cognitive decline. Safer alternatives. Abrupt cessation of a benzo is dangerous and can be life-threatening. A slow, medically supervised taper is mandatory. Non-sedating anti-anxiety medications like buspirone and non-pharmacological interventions like cognitive behavioral therapy, CBT, for anxiety and insomnia are safer long-term options. Medication number 4, amitriptyline Elavil, a potent anticholinergic for pain. Amitriptyline Elavil is an older generation tricyclic antidepressant still widely prescribed for chronic pain, especially nerve pain, insomnia, and sometimes migraines. Mechanism of harm. Extreme anticholinergic load amitriptyline is distinguished by having one of the highest anticholinergic burdens of any commonly prescribed medication. It is a powerful blocker of acetylcholine, which means that its effects on memory and cognition are not merely a potential side effect, but an expected consequence of long-term use. The evidence. A massive 2015 study published in JAMA Internal Medicine examined over 3,400 older adults and found that those who took higher cumulative doses of anticholinergic medications like amitriptyline over a 10-year period had a 54% greater chance of developing dementia. The effect is cumulative and often silent, with a gradual erosion of brain power that mimics natural aging. Safer alternatives. For nerve pain, newer medications like duloxetine or gabapentin offer relief with a significantly lower anticholinergic burden. For insomnia, low-dose doxepin, an older drug but with a milder anticholinergic profile at low doses, or melatonin can be used. Medication number 3, paroxetine Paxil, the anticholinergic SSRI. Paroxetine Paxil is a selective serotonin reuptake inhibitor, SSRI, used for depression and anxiety. It is often chosen with the belief that it is a modern, gentle antidepressant. Mechanism of harm. The uniqueness of anticholinergic SSRI action paroxetine is unique among the SSRIs because it is the only one that possesses significant anticholinergic properties. Unlike its siblings sertraline, Zoloft, or citalopram, Lexapro, paroxetine actively interferes with acetylcholine, making it a dangerous choice for older adults. The evidence. A 2021 review published in Frontiers in Psychiatry, comparing the cognitive profiles of elderly patients on different SSRIs, found that paroxetine users showed measurable declines in short-term memory, verbal recall, and attention span within the first year of use. They were 30% more likely to show early signs of cognitive impairment compared to those on other antidepressants. Safer alternatives. Paroxetine is on the American Geriatric Society's Beers criteria list as a potentially inappropriate medication for older adults. It should be avoided. Safer alternatives with no significant anticholinergic activity include sertraline or citalopram. Medication number 2, antipsychotics, the chemical straitjacket. Antipsychotics, including quetiapine, Seroquel, risperidone, Risperdal, and olanzapine, Zyprexa, were developed for severe psychiatric conditions like schizophrenia and bipolar disorder. Alarmingly, they are now frequently used off-label in nursing homes and hospitals to manage non-psychotic issues in the elderly, such as insomnia, agitation, or behavioral changes associated with dementia itself. Mechanism of harm. Dopamine suppression and sedation. These potent drugs suppress dopamine, the chemical critical for executive function, motivation, and personality. The result is a profound chemical sedation that slows the brain, often causing patients to appear zombified, dull, and emotionally flat. The irony is that they are prescribed for dementia-related agitation, yet they often accelerate cognitive decline. The evidence. A comprehensive 2022 study in the Lancet Healthy Longevity found that older adults prescribed antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even without a prior dementia diagnosis. Additionally, these drugs carry black box warnings due to increased risks of stroke and sudden death in this population. Safer alternatives. The management of behavioral and psychological symptoms of dementia, BPSD, must prioritize non-drug interventions, creating structured routines, addressing pain, reducing overstimulation, and improving sleep hygiene. When medication is unavoidable, low dose, short-period use should be the goal, and careful consideration should be given to severe risks involved. Medication number 1, anticholinergic polypharmacy, the cumulative decay. The single greatest medical threat to minds of the aging population is not one drug, but the insidious, silent effect of combining multiple drugs with anticholinergic properties, a phenomenon known as anticholinergic polypharmacy. The mechanism. Synergistic blockade. Imagine a scenario where a senior takes diphenhydramine, anticholinergic number 1, for sleep; oxybutynin, anticholinergic number 2, for bladder control; amitriptyline, anticholinergic number 3, for nerve pain. Each medication, alone, imposes a burden on the brain's already dwindling acetylcholine. Together, they compound this effect, and the cumulative anticholinergic burden, CAB, skyrockets. The multiple simultaneous blockades overwhelm the brain's ability to communicate, causing a rapid decay of neuronal function and mirroring the pathology of advanced Alzheimer's disease. The evidence. A 2022 analysis published in Age and Aging tracking over 280,000 older adults found that those with the highest cumulative anticholinergic burden had a 120% increased risk of developing dementia within 10 years, more than double the normal risk. Crucially, most of these patients were unaware their routine medications were anticholinergic. The solution. Deprescribing and medication review. The most empowering part of this finding is that drug-induced cognitive impairment is often reversible. When the chemical burden is lifted, seniors frequently regain significant clarity, energy, and memory function within weeks or months. The critical action required is a comprehensive medication review. Patients and caregivers must ask their doctor or pharmacist to evaluate their entire list of prescriptions, OTC drugs, and supplements for their anticholinergic load. The goal is a process called deprescribing, slowly and safely tapering off unnecessary medications and switching to non-anticholinergic alternatives, rebalancing the brain's chemistry, and giving it a chance to recover.